numbers as compared to the last one. Right. So the timing of doxorubicin-induced cardiotoxicity. We'll want answers here so that we are able to discuss the salient points around. So what is the answer here? What is the answer here? B. May develop up to 1
B.
year post stopping therapy. Can it happen even later?
Yes, sir.
You need not actually type the chat in the chat box. Be open, unmute and talk. So these are certain salient points. The question is actually very weird. It can be anywhere. Exactly. So it is acute if it is very short, occurring initially during the first 2 to 3 days. Acute cardiotoxicity is actually very less. Chronic cardiotoxicity in certain of these studies have been told as less, but compared to chronic, acute is less, right? So do not get into the numbers of the incidence. It varies from the studies to the studies. Acute change, we do not know the mechanism. It can be myopericarditis or all your rhythm disturbances. Which one is it talking about? Which one? Of what? My iPad. Can you unmute and talk?
So it's not clear whether it's talking about acute or subacute or chronic cardiotoxicity.
Exactly. So we don't know what they are wanting to ask in the question. So for all practical purposes, any doxorubicin-induced cardiotoxicity, just remember only the chronic part. That is more commoner. There are reports of acute being commoner than chronic, but across the board, chronic cardiotoxicity of anthracyclines is the classic cardiotoxicity of that group. Okay. Acute is usually all your rhythm disturbances. Very rarely can be an LV failure. But acute LV failure is reversible. Chronic cardiotoxicity usually evident after a month or so, but it can develop even 6 to 10 years after administration. Okay, so you have to the discussion we usually have up with the drug dosages. For doxorubicin, for this 500 to 550 per meter square, uh, 500 to 550 per meter square, the incidence of cardiotoxicity is 4%. When it is 551, it goes up to 18%. You got it? So, and by 600, it is crossing your 36%. Just wanted to highlight on that. Any mediastinal radiation or concurrent cardiotoxic anti-tumor drugs are high risk factors for early onset or very sure about adriamycin-induced cardiotoxicity. All 4 chambers will be dilated in a doxorubicin cardiomyopathy, and it is dose related. Mechanism is even more important. The mechanism for cardiotoxicity of anthracycline is different from the mechanism of its efficacy. Got it? The anti-tumor effect mechanism is different from the cardiotoxic mechanism. Where is it common? I mean, where is it same in both? In which group of
Trastuzumab, sir.
Yeah, so trastuzumab, it is basically again cardiac ERBB2 signal blockade. Got it? So the mechanism of cardiotoxicity and the mechanism of the anti-tumor effect of the drug is same in trastuzumab as opposed to anthracycline, wherein oxidative damage is the predominant mechanism. And you know, adria cells, it is cumulative dose independent, dose, they have given it is wrong. So dose dependent cumulative effect. Here it is a dose independent effect. GTN, which is not a high risk met.
Lung, sir.
Lung.
So which stage is lung?
It's
3.
a stage 3.
3.
Why is it stage 3? How do you place your seminomas of lung? Good risk or poor risk?
Good risk. Good risk.
Okay. Non-seminomas of lung?
High risk, sir.
Good or intermediate?
High or intermediate?
Intermediate.
Intermediate.
High, sir.
High or intermediate?
Intermediate.
Some
High
high.
risk.
Who wants it called as high risk?
High risk, sir.
So what are all the high or the poor? It's not called high risk, it's called poor risk. What are all the poor risks of NSGCT?
S3, sir.
S3.
H3 or mediastinal primary
Okay.
and non-pulmonary visceral mets.
Yes.
So why it's non-pulmonary? No. So pulmonary cannot be a poor
High
risk.
risk.
Right?
Poor risk.
So it is intermediate of NSGCT, good in seminoma, and stage 3 in GTN. All these germ cell related tumors are very common in lung and a curable condition in this lung. And second thing, which other cancer do you differentiate your metastasis based on the organ?
GTN and
Any other?
germ cell tumors.
The both of that we have discussed now. Any other tumor you differentiate based on the organ, different metastatic peculiarities.
Melanoma, sir.
Lung.
Melanoma, very good.
Prostate.
Melanoma, too good. What is the stage 4 of prostate?
Node positive or
Node, regional
metastatic?
Even node positive is stage 4. Perfectly okay. Which node?
pelvic.
Is it pelvic node or inguinal node or both?
Both.
Good. So can be extending with or without genital tract involvement also. Okay. None of these germ cell tumor treatment or staging anything. I mean, it has not got anything new in it. So no updates in this area of oncology. Post third cycle PEMSIS. Probably that was NSCLC. Can SCLC be also treated with pemetrexed cisplatin?
Sir.
Can small cell be treated with pemetrexed cisplatin?
No, sir.
Sir.
Because of thymidylate synthesis.
What is the chemotherapeutic regimen for NSCLC?
Sir, depending on the histology, sir, if adenocarcinoma will give pemetrexed cisplatin,
If it is adenocarcinoma, is only PEMSIS okay or Paclitaxel is okay?
the Paclitaxel is also okay, sir.
Anything else?
Better is PEMSIS.
So better is PEMSIS is based on what content?
Trial based upon the.
It is based only on theoretical basis. There is no trial proving that. So treatment is supposed to be called as platinum-based doublet. The second agent can be anything. Can be mineralopril, it can be etoposide, paclitaxel, pemetrexed. Okay. This was purely based on the company which wanted to promote pemetrexed more for adenocarcinoma, that they found mechanisms for the same, and gemcitabine for squamous cell carcinoma. You can use it, but for all purposes, what in practice we are using is PEM restricted to only adeno, but gemcitabine kind of crossing over to all. Okay. For small cell carcinoma, what is the platinum doublet?
Etoposide.
Can it be another non-etoposide doublet?
Yes, sir.
Yes, no, don't know.
Yes.
But the problem of SCLC is why no big trials are happening in small cell.
The poor survival.
So what? You want to give something and improve survival. That is what you are working for. Why no big NGS developments in small cell? NSCLC, you want all NGSs happening.
So driver mutations.
Yeah, they didn't find, no. We
So
don't
it already has high tumor burden, sir. So immunotherapy will work. We don't need to.
Does that mean we don't have to find out a driver mutation? If there is a driver mutation and high PDL1, what do you choose?
Driver mutation.
Driver mutation.
So PDL1 high is not your preventive factor to find a mutation or the
So
problem
since
of
the main treatment is chemo radiation, the treatment modality, so we are not good.
in an
For
extensive
refractory, they are testing, no? Like they test topotecan or lurbinectidine or other
so
agents.
on the whole, we are restricted to 3-4 agents. Okay, that is mainly because the availability of any small cell lung cancer tissue for a extensive workup. One, the incidence itself is low. Second, to prove small cell was easier, and further diagnostic tests have never been possible. One, because of the availability of the tissue. Second thing, whatever they have tried so far has not yielded them any positive driver mutation. Rather, it has been universally TP53 positive and stuff. Okay. And it is more, as you tell, more of tumor burden, tumor mutational burden. But which type of small cell is immunotherapy now approved? I mean, which stage?
So it is both for extensive and limited.
Kelly and Kelly also.
Do you give along with the chemo and then switch maintenance, or do you do switch maintenance or along with the chemo?
Along with
In
chemo
extensive
and then
stage, we give
maintenance also.
along with chemo, sir. In limited, I think we'll use after
So why is
induction.
this?
Because of radiation associated with limited. It can cause increased lung toxicity with concurrent use of immunotherapy.
Then you give concurrent chemo radiations with immunotherapies are coming up.
Yes, coming up, sir.
Yeah, then why not now here? What is the funda of switch maintenance?
To reduce recurrence.
If you are able to give from the 5th cycle, if you are able to give after chemo, why not give with the chemo also? Why the passive? 1 second, sorry. Where are we? Why is this switch maintenance in some are along with immunotherapy, chemotherapy? See, again, I tell you, no point in remembering atezolizumab or pembrolizumab, nivolumab, which is the PDL1. Very difficult to remember. Even during practice, you'll have to go back to see your books. But remember the basic concepts behind that.
If you want to delay progression, like after the
Yeah,
treatment
correct. That
of
is their
lymphatic-
thought process. But for delaying progression, why don't you give along with the first cycle of chemo only? You wait for 4 cycles of chemo, then you want to start immunotherapy after that. See, where is avelumab approved?
bladder cancer.
1 second. Only 2 areas that the avelumab got approval.
Merkel associated carcinoma.
Anything else?
Bladder
Cement,
cancer.
metastatic bladder
Other bladder
after chemo. Metastatic bladder after chemotherapy, sir, as a
Yeah.
maintenance.
Yes.
One more.
After
Merkel cell carcinoma.
non-pathological complete response also.
No, you tell me the cancer alone. Bladder.
Merkel cancer and urothelial.
Merkel cancer.
Urothelial is bladder. What is the
Yes,
third
sir.
one?
Merkel.
Bladder, Merkel. Third one. Renal cell carcinoma, axitinib, avelumab.
Okay.
Right? It's only 3 areas. This is to be remembered because very short, very less number of cancers are having its approval. And avelumab is given after chemotherapy in bladder. Durvalumab is given after chemoradiation in lung. And many of such trials are in even small cell lung after chemoradiation, they are starting Tazoli and this and durvalumab, all because one, with chemoradiation, there is huge amount of new antigen production, which is going to help you in immunotherapy to work. So the concept behind that is they think the tumor mutational burden might rise after a chemoradiation completion, which will be an advantage for starting your immunotherapy from then. Second thing, you are able to kind of enrich your population. After chemoradiation, after 10 patients, if 7 are responding and 3 progress, you are not going to give immuno for the 3, right? So only the responders are getting into the trial. So they will give you a better survival rather than if you are starting immuno along with the first cycle, you will not know who is going to actually worsen, who is going to benefit, and whether the benefits are, whether the patients who are responding are going to get additional response with immuno. Am I clear?
So you're talking about immunomodulatory effect, no? So it can be even after
It's
1 to
not
2
modulatory
cycles of
effect.
chemotherapy.
Immunotherapy given a switch maintenance. Switch maintenance word means after chemotherapy, giving immunotherapy. Like your Pacific trial, this, that. Your bladder trials, all. First 4, 5, 6, whatever number of chemotherapy alone without immunotherapy, then immunotherapy is based on 2 concepts. One, you filter only the responders to be put into your trial. All the progressors will be taken out of the trial. Obviously, no. Second, because of this chemoradiations or chemotherapy, there is good production of new antigens because of necrosis and so many things. And these are the targets for your immunotherapy. Am I clear now?
And so how is immunomodulatory effect different then? Like,
Do not use that immunomodulatory word. That is used more in your immunomodulators.
okay.
Got it? Where do you use immunomodulators?
Multiple
Multiple
myeloma.
myeloma, sir.
Anything else?
Follicular lymphoma.
So all your hematological malignancies are using this property of immunomodulation. Lenalidomide is given not only in multiple myeloma, it can be given in lymphoma as well, right? So hematological malignancies have this advantage of giving immunomodulators. Why not immunotherapy in hematological malignancies?
PDL1 expression is less.
Yes, sir. In
PDL2
Hodgkin
expression more.
lymphoma, it's coming.
PDL2 is more
Hodgkin's
than
lymphoma, we are
PDL1.
using.
I am getting so many answers.
PDL2 expression more than PDL1.
Exactly. So PDL2 is high. So no point of inhibiting PDL1 or PD1. That is the reason for hematological cancers not getting immunotherapy. Right? So coming back to this question, we are talking so much extra content. What is this? Anemia with nephrotoxicity. So what is the answer? Hello, anemia with nephrotoxicity. What is the answer? They have given anemia so specific for you to choose the correct answer.
Methotrexate.
Why? That is why you give butol and folate for methotrexate, right?
Yes, sir.
Right, perfect. Answers are right. Pembrolizumab nephrotoxicity is going to happen in very small number. Predominantly eliminated through renals. So, pemetrexed is contraindicated in a renal compromised patient. Okay.
Okay.
Stage 1B2. This is the most horrible question which can be asked. What is the answer?
So we are
ATRT
confused
cannot have
between B.
Right. Stage 1A, what is the answer?
radical hysterectomy.
Surgery, right? Leave. Fertility sparing, non-sparing, radical, non-radical, simple, put whatever words you want. Surgery is the answer, right?
Yes.
Stage, which stage onwards? Only chemoradiation.
1B3.
1B3.
2A2.
2B onwards is only chemoradiation. Okay.
So even for 1B3, it is very difficult to get clear margins like
One
with
second,
surgery
sorry,
because
sorry.
it's more than 4
One second.
centimeters. Hello?
Just a second, I'm on an emergency call.
खुशी गाना नहीं गेट बंद कर इधर आ इसमें मेरे को म्यूट कर देते जब आवाज जाती है तब बंद कर दे बोल मत
Right. So the daisy area is between 1B to 2A. You call it 1B, 1, 2, 3, 2A, 1, 2, whatever it is. Grossly to remember, 1B and 2A are the most difficult gray zones. Yes?
Yes, sir.
Abba.
Yeah.
So whenever you are preparing, prepare like this because it's very tough for you to remember 1A1, 1AB. I mean, to remember that stage only is going to be difficult. And then, treatment for the stage is even more horrible. So now comes the confusion again. So I'll show you this. 1B1, 1B2, 2A1, 2A2. Okay. All this have both the options. There is an R here. So above that is surgery, below that is radiation. Okay. Don't go into the details. Clear? Paratic, should we do or not? What is sentinel node, pelvic? Nothing to be remembered. Surgery or radiation, both are options. 1B3 and 2A2 also, radiation or surgery is also an option. Clear?
Okay. Yes.
Understandable? 1A, surgery is confirmed. There is only one thing to remember from surgery, only surgery is 1B1 having some conservative surgery criteria can be purely surgery. So that is again not to be remembered. So many factors are there to decide only surgery or not. Okay. So again, putting back into a single line, 1A surgery, 2B onwards, purely radiation. This R's will not come. This or that will not come. The whole confusion is only from 1B and 2A. 1B of 1, 2 or 3, 2A, 1 or 2, whatever it is. So these two stages only confusion. 1B and 2A. Clear?
Yes, sir.
In this, I
Yes,
want
sir.
you to see radiation can be an option for patients who are medically inoperable. That is given as N. See, these are dissections of what can be done in the best way. So for 1B2, pelvic EBRT, M and N. So M and N is radiation can be an option for patients who are medically inoperable. So 1B1 and 1B2, yes, surgery. If medically inoperable, radiation. Now what is the answer here?
Radical hysterectomy.
Wait, we'll go one by one. Chemoradiation followed by brachytherapy is out. Clear?
Sir, but the main meta-analysis, green meta-analysis, which was done in cervix carcinoma, it was from stage 1B2 to 4A.
Even even your neoadjuvant interlaced trial is from 1B.
But
Sir,
You
that
got
was
it?
from previous staging.
Said please radical hysterectomy only.
So what is this question? Is this a new staging or previous staging? 1B2 is
It
a
will be
new staging, right?
2018.
2018
Sorry. Let's go one by one. At least D is out. Neoadjuvant chemo followed by surgery is out. Option D is not wrong. Yes, no.
Yes, sir.
Yes, sir.
Chemo followed by interlaces could be considered is given here. See, induction chemotherapy, point number P, followed by a single agent chemo and radiation according to interlace protocol could be considered. It is not still the standard of care, but it is also an option. Okay. So that is their standpoint on that. But neoadjuvant chemotherapy followed by surgery is never an option. So that is out.
Yes, sir.
Only radical hysterectomy can be done
Yes,
Yes,
sir.
sir.
Yes, sir.
without addressing the notes.
So why 1B
The
will have
radical hysterectomy.
1B2 will not have nodes. It will be stage 3, no?
One
3C. If nodes are positive, it will be stage 3C.
But still, even if
not
notes are
asking
negative, we
for
have to remove.
positivity, you are doing surgery. It can be stage 3C after surgery.
Sir, after
Sir, but
surgery,
in the
apart,
options, sir,
depending upon Peters and Sedley's criteria, we'll decide about the adjuvant
Yeah,
treatment.
understood. So let's go into the whole story again. Clinically, if stage 1B2, will you do only surgery or will you do lymphadenectomy also?
We will do
Sir,
lymphadenectomy.
radical
look for
hysterectomy
lymph
includes.
Radical hysterectomy means in
Includes-
lymphadenectomy with
Yes.
Hmm?
So it includes lymphatic dissection.
understood. I am not talking about the word of radical here at all. So 1B2 means you do hysterectomy and nodal dissection. Yes.
Yes, sir.
Yes.
Yes, sir.
So that is called radical. Yes.
Yes, sir.
Yes, sir.
Abba. So that part is confirmed. This radical surgery followed by radiation and brachy is for which patients?
So
who
high
are
patient.
like triple Peters criteria positive, or if they are positive for this uh,
Sedley.
Sedley's of Peters criteria, it's chemotherapy.
Peters for radiation or
Yes.
both?
Only.
Peters for chemoradiation, Sedley is for radiation alone.
And this is for radiation only. Okay. Peters is more easy to remember. The mid one, positive nodes, positive margin, positive parametrium. Yes.
PPs.
Wherein you have a chemo radiation, but these fellows have not given the option of what happened to that also. So what to choose, I also don't know. If this is the question, and
Is it not like for 1B2 we directly go with radical hysterectomy alone? Then if there are any high risk futures, then we go for the adjuvant radiation.
exactly.
Then
So
only.
if we take that way into account, so we have to believe that there is no high risk features and I mean tick only A. Is that right?
Yes, sir.
Yes, sir.
That is how we will have to take it. You believe that there is no high risk features, and the question cannot be formed this way. That is wrong again. Okay. A question should be complete so as to have the options exactly matching the answer what is asked in the question. Right.
Sir, can we expect at least even after the exam, someone would have scrutinized the paper and, gave the key from the national board?
Not going to happen. Not going to happen. These are common man expectations, acceptable, but it will not happen. So remember such things only grossly. You need not dig into the every aspect of it. Okay. So this is your CELDIS, primary tumor size, stromal invasion, LVSI, that meets CELDIS criteria, radiation alone. Okay. Clear. This much to gain from cervix is okay. Prostate, vertebral mets, one lesion in L1, vertebral collapse, cord compression, mild neurodeficit.
It was early card compression, sir, in the question.
Okay, early cord compression. So what are the reasons for cord compression in prostate CA?
Sir, vertebral mets.
What else? Sir? So it is either a bone collapse and compression or a soft tissue and compression. Okay.
Yes, sir.
So how do you deal both?
Sir, spine stabilization first.
So where do you give radiation? Where do you give surgery?
According to MNOP algorithm, we follow like mechanical, neurological, and
So
oncological,
what is the
and
first mechanical story?
like whether the spine is like in an instability or in a stable form.
For this question, what is answer? MNOP.
For this
B.
question, spinal artery with
Spinal-
boost to L1, sir. Like
So B.
it has been mentioned
Stabilization.
peculiarly that he's 78-year old, and it is not a single lesion, it is a multiple lytic lesion, and one lytic lesion is there, and that is causing mild compression like
With
Bilski
mild
type 1.
neurological deficit.
Mild
So, but
neurological deficit.
stabilization surgery, because there is only the deficit, neurological deficit has just started. So we can
Spine
stabilize.
stabilization only.
Right.
78-year-old.
Okay. Let's go in stepwise manner. One, you have an continuing chemotherapy is not the option, so it's fairly ruled out.
Okay, sir.
Yes. Immobilization is brace. Yes or no?
Yes, sir.
No, sir.
I mean, I'm not telling that alone as the answer. Will you do or not?
Yes, sir. We'll do it later.
You will not do it later. You will start off with that and put the patient for some local therapy. Yes.
Okay.
Right.
But sir,
Zoledronic
is
acid,
that the
yes or no?
definitive management, immobilization with brace and
Yeah.
zoledronic?
Yeah. So they are asking for a definitive management. Understood. So immobilization with brace is also a part of the treatment. Yes or no?
Yes, sir.
Yes, sir.
Yes.
Okay.
Zoledronic acid, yes or no?
Yes, sir.
Yes, sir. Yes, sir.
Why zoledronic acid?
Sir, bone mets.
Lytic lesion.
Oh, so what? You can give aram se later. No. Why now?
Sir, hypercalcemia due to.
If it comes, it comes. If it doesn't come, it doesn't matter. No. Is it for pain? They are not given pain.
For fracture risk.
To
What is
prevent other skeletal related events.
skeletal related events. What are the skeletal?
Myeloma effect type.
No, what are skeletal related events? SRE.
Pathologic fractures,
Fracture.
other spinal cord compression, hypercalcemia, pain.
Radiation, surgery, pathological fracture, or hypercalcemia.
So spinal cord compression, pathological fractures, this, that, all. There are 5 SREs. Fracture, cord compression, pain, hypercalcemia, one more.
Need for radiation or surgery.
Wonderful. So for SREs, you give bone modifying agent, which can be zoledronic or denosumab. So that is also one of the options, right? So that is not a definitive treatment. So now you are very clear with the question that you wanted some definitive treatment for this patient. Clear?
Yes, sir.
So D and C are not your options. Clear? Yes?
Yes, sir.
Right. Now between A and B, when do you do a spinal stabilization surgery for any patient with a lytic lesion? Leave around only prostate.
And it is
Depending
single
upon the spin score.
Single lytic lesion.
Single lesion when the plan of management is curative.
Okay. If the plan of management is not curative, can you still do a stabilization surgery?
Yes, sir. We
Yes,
can.
sir.
So when the neurological deficit has not yet established, so as to prevent.
There is a vertebral collapse. What do we do? Surgery or wait for the radiation? And radiation
surgery, sir.
collapses the vertebra.
Surgery, sir.
So we'll do a surgery.
So there are multiple lesions. One funda is good, correct. If there's a single lesion, good. In a curative intent, you are doing surgery, okay. If there is a vertebral collapse, the collapse is causing a neurodeficit. Will we still give radiation and worsen the collapse?
No, sir.
No, sir.
So if there is a soft tissue compression of the cord, what do you do?
So that time we can give Bhatti.
Wonderful. Answer is there with you now. Clear? This is another bizarre question.
Sir, answer is
What is the answer? Spinal
Surgery.
artery.
Surgery.
No, only all you people told.
Sir, if this question was instead of lumbar spine, it was thoracic spine, like then surgery would have made sense. But spinal cord is ending at L1, no? So, and the age is also there. It is 78 years. We don't know about the performance status.
We
So
don't
should
know
we
anything
still?
about the question. Then. With this available words, only this was the answer. That is what I can understand.
the answer is surgery, no?
Yes, sir.
To me, it is surgery.
Okay.
Okay, sir. I'm
All-
not surgery.
All factors put into account acceptable. See, we are not telling you cannot give radiation. There is a collapse already. The collapse is causing a compression, and I go and give a radiation worsen the vertebral collapse will actually not make sense, even if it is a multiple lesion and that area is symptomatic.
So in sin score, vertebral cord, body collapse, it has 3 points. So
Yeah. What is SINS? Final.
spinal instabilities, neoplastic score.
Components.
So location, pain, type of lesions, deformity, and some other things.
What is that as the thing?
Collapse and something else. I forgot.
What is the first thing it should do?
So location, which area of the spine it is,
Again.
cervical, thoracic, lumbar.
Second.
Pain,
Where
whether
is the
pain is there or not.
Where is the pain in the question? That is what I have been asking for. They have not given pain also.
Yes, sir.
So with the available information, that this is the possible explanation which I can give you. Right, next question. I have 120 questions. Come on, finish it off.
Okay, sir.
9:45 already. And this question paper is like, if you want to discuss, you can discuss for every option. INI was far, far better. Right, what is the answer here? ALL post-treatment, prophylactic anaphylaxis,
Pituitary adenoma.
Radiation-induced secondary malignancies.
What malignancy?
leukemia recurrence, yes, no?
Yes, sir.
Is it possible at all? Is it totally not possible? Sorry.
Possible, sir, but
Question
initially
comes-
leukemia
let-
present, meningeal.
let all the theories be separate. A patient with ALL comes to you post-treatment and post-cranial artery, whatever is the treatment. Now you are having patient with headache and diplopia. What is your first differential?
Leukemia recurrence.
That's
Recurrence.
all. Okay, so all are possible. But the question wants you to remember that is the most common, right? Pituitary adenoma is possible, yes. Radiation-induced second malignancy is possible. Cerebrovascular side effect is also very rarely remotely possible.
But after 2 years, severe cerebrovascular side effects will be there.
These are remote events, case reports, doesn't matter. What for this question, the answer is leukemia recurrence. Clear?
Yes, sir.
Yes, sir.
These are questions designed to make you understand what will be your thought if such a patient comes to you, right?
So radiation-induced second malignancy will be what? Like which malignancy?
Who cares now? That is not your answer also, leave it.
Leukemia recurrence happens within the leptomeningeal sites, right? Why will it present with diplopia, headache?
Yes, can.
Leptomeningeal will
It
present
will
with
lead to increased
present with
intracranial pressure, and that's why there'll be headache. And
Any CNS recurrence can present in any nonsense way. There is a leukemia cell inside the CSF. It can deposit on a cranial nerve and cause cranial nerve palsy, and that can be the only presentation. It can sit on near your pituitary and cause diplopia. It can cause total optic neuropathy. So it can be any reason that you are having diplopia because of a leukemia inside the brain. It can be a it can be a leukemic infiltration meningitis sitting near your
Stones, basal systems.
areas. Okay. So all nonsense possible. Every other patient who comes to you with any bizarre manifestation, the take home point, anything which is not explainable in a post-treatment leukemia, think always recurrence. Someone comes with coagulopathy, it could be a recurrence. Someone comes with metabolic acidosis, it could be a recurrence, right? First, rule out recurrence through all possible means. Get your CSF done, get your bone marrow done. If CSF is negative, repeat CSF 2-3 times. Okay.
So cerebrovascular side effects are due to LS sparginus.
Could be due to anything.
Cytraben.
Huh? Could be due to any drug, no. So you cannot pinpoint to all this after
Even after 2 years, like
even after 2 years, you are asking if CVA is possible. Yes, possible.
yeah, because of the anti-leukemic drugs. Which drugs?
It is possible. We cannot pinpoint any drug. The treatment as a whole can have a metabolic syndrome, any nonsense happening. I mean, when I searched rare reports of CVA, so that is not our content of discussion at all.
Okay.
It's all some rare events. Someone, if I have a patient CVA reported, I'll report. Doesn't mean that this patient is because of this drug that is caused. Okay. 11:22 evenings. Okay.
Yes, sir.
How do you, what test do you do to see this translocation?
Fish,
PCR?
break apart fish.
Break apart fish. Why?
Because we know the locus, like where it is getting translocated to. So we'll do a break
No,
apart.
or you don't know.
Since the partner can be different each time, so
Right. So the partner can be different each time. What is the partner here? Which is constant and which is variable?
EWS is constant.
22 is constant.
Good. So FLI1 is most common. EWSR1 can be with FLI1, ERG, ETV, ETB, FEV. All these are possible. Okay. But most common is FLI1.
Okay.
Yeah. What is this TAD, DBD? Okay. So many questions. Melanoma, most common mutation?
The BRAF.
What are the other mutations? BRAF1.
Secret.
NRAS.
Very good.
BRAF one
RAF, KIT, RAS.
NF, sir.
CDK into a.
So BRAF, V600, ERK. Most often it is V600E. Okay.
Yes, sir.
These are also to be remembered. Some points are extremely important to remember. V600E followed by V600K.
Okay.
600E is 80%. Okay. Only V600 mutations are sensitive to BRAF inhibitors. Okay.
E or K both, or only E?
E or K. 600 number alone.
Okay, sir.
On that, E is more common. That is all.
Okay, sir.
Okay. Next, KIT. That is again present in around 10 to 15%. Okay.
Okay, sir.
RAS, you just now told me. RAS is also possible. Approximately 15% again. Okay. That is all. BRAF V600 is proven through IHC or PCR? IHC.
PCR.
Can you do IHC? There is a big thing here. V600 E1 IHC test may be used for rapid screening. Okay. That is for starting your BRAF inhibitor. Good sensitivity and specificity. KIT, there is no IHC. Okay, because there are so many mutations. PCR can also be done for rapid assessment. Clear?
Okay.
Right. Vulva, what is the poor prognostic factor? See, which is not a prognostic factor.
Grade.
Tumor grade.
Perfect.
Tumor grade.
Nothing much to there. So grade all are depth of invasion, positive influence, LVSI are poor prognostic factors.
So
What
we
is-
use the phrase
T4B.
stromal invasion and not depth of
T4B.
invasion in vulva.
Sorry?
We use the term stromal invasion in vulva. We do not use depth of invasion. No?
See here, depth of invasion.
Okay. In the textbook, it is stromal invasion.
Nothing is NCCN again. Leave it, whatever. Who. And recurrence and survival, depth of invasion. Where else is depth of invasion very important?
Tongue.
Head and neck cancers.
Head and neck.
Oral.
Wonderful. What is this?
It was PUD orange.
T4B.
P4B.
This one?
Not a
All
criteria.
these are phosphate.
Phosphate less than 4.5.
So this is classic numbers to be again remembered. Calcium less than 7. But we never had any TLS question asking numbers. And this, when I went through all the questions, I think 4 topics, if you have read in depth, would have actually cleared the exam. SVCO, corona score, and this tumor lysis.
DLS. And AI.
AI. Right. And
Febrile
25%
neutropenia also.
that is all is needed. AKI creat is more than 1.5 times the normal. Arrhythmia, seizure, tetany. Not seen in tumor lysis.
Respiratory failure.
failure.
Respiratory failure.
Least gonotoxic.
Methotrexate.
Is it busulfan or methotrexate?
Methotrexate.
Metho.
Why metho? Why not busulfan?
So all alkylating agents are more
Wonderful.
gonadotrophic.
So what are the alkylating agents here?
Cycloiphosphate, busulfan.
So the B, C, and D are. So best is to remember the alkylating agents. Cyclophosphamide, iphosphate, easy to remember. Don't forget busulfan, chlorambucil, melphalan, procarbazine, and carmazine. Okay. All these are again alkylating agents only. Okay.
And so we use methotrexate in GTN, no? Like if you didn't,
Yeah.
it wasn't safe, we wouldn't be using it.
Okay. Next.
Cyclophosphamide.
Cyclophosphamide.
Answer is easy again. Which cell?
Leydig cells.
Hello.
Spermatogonia cells.
Differentiated germ cells.
Leydig cells.
Okay, sorry. Okay. Yeah.
Sertoli
Self-producing
cell, yes or no?
testosterone is Leydig cells.
Sertoli cell, yes or no?
Yes, sir.
No, sir.
No, sir.
Abba,
Which
Sertoli
cells produce testosterone, they are asking, no?
Wait. Which cell will produce what? Leydig cell will produce what?
Testosterone.
Very good. Sertoli cell will produce what?
So secreting factors which help to nourish the cells. Germ cell.
Okay. What is spermatogonial cell?
It's a germ cell.
What is germ cell? They are given both.
So Leydig cells are answer.
So they asked about testosterone production.
Yes, sir. They asked regarding testosterone
Not
production.
azoospermia, no.
It was a question, but options were different.
Okay. So
One of the
asked
options was
about testosterone, Leydig cell. They
other
have
option
asked about azoospermia.
No, so they asked about testosterone production.
Right. Okay. So gonotoxic damage to testes will result in impairment of some. Sorry. Less frequently testosterone production, which is largely due to reduced sensitivity. So Leydig cells, which is resistant to cancer, anti-cancer drug, is it Leydig cell or germ cell?
Leydig cells will be more resistant and germ cells will be more sensitive.
That is all. Remember that, you can answer the question. Hemolysis, with how many days?
5 to 10 days.
1 to 5
5
days.
to
5
10
days.
days.
Why not in the initial 5 days? Will it wait and why then prophylactic?
Sir, in this definition, it is 3 days before till up to 7 days after.
Yeah, they in the question they asked how many days after.
Yes, sir. 1 to 5 days, sir.
1 to 5 days.
1 to 5 days.
1 to 5 days, sir.
Yeah, that's all. These are questions from nursing MCQs. Which is suitable line, this, that. All your line related questions more from your nursing MCQs. I don't know how they want. And that is why one of the option was call the doctor.
Yes, sir.
Most suitable line for short-term chemo administration. What line?
Pick line.
Peripheral IV line.
Pick line, sir.
Peripheral IV.
Peripheral IV.
I don't know.
Peripheral IV, sir.
Central line, port, both are not there. If I am given a chance, I'll put peripheral IV line because that is what is commonly used. But if there is someone to give a pick line, I'll better put pick also. But most suitable answer for this question is peripheral IV line. Okay. Now again.
For the tumor lysis, it's 5 to 10 days or 1 to 5
1 to
days?
5 days. Right. What is this?
Sir, for TLS, what is the answer?
1 to 5
C.
days. 1 to 5 days.
Okay, sir.
C.
C. It is stage 3. You are confirmed with that.
3B is
C.
C.
I think someone of you actually discussed the same question prior to exam also. Right. See, involvement of spleen and involvement of lymph nodes on both sides of the diaphragm, which may also be accompanied by extra lymphatic extension or by spleen or both. So stage 3 is both sides of the diaphragm. There should be a lymph node. Am I clear?
But they specifically asked Ann Arbor modification, this Lugano modification of
Probably, yeah.
Ann Arbor staging. Yeah.
Oh my God. Then it is 3BS only. Very simple. Right?
The answer is
3BS.
yes.
There is no X now. The bulky term has been taken out. Okay. What is the answer here?
Oh my God.
Pulmonary thromboembolism, high flow oxygen requirement, hypoxia. What do you do? Thrombolyze, yes, no.
Yes, sir.
They haven't mentioned about RV dysfunction, troponin levels, and nothing is mentioned, sir.
So with this available words in the question, what is your thought process? What do they want to split into? How do you dichotomize your
Sir, usually if the patient is stable,
Hemodynamically stable patient, we
hemodynamically
will
stable versus unstable? Okay. So if this positive for pulmonary embolism, all your imaging is positive for a pulmonary embolism, you see acute management using anticoagulation only for you do thrombolysis only for these patients for hemodynamically unstable pulmonary embolism. Okay. Clear?
yes, sir.
Yes, sir.
Right. So thrombolysis is out. First A and D are out. Now between B and C.
Thing is, sir, do we usually start directly oral anticoagulants directly? We generally give 1 week of heparin, Clexane, then change over to oral.
That is yes, but that is not their thought of asking these two. You do
We'll start
heparin and
So if the patient is stable, we can do thrombolysis, no?
Right. In an anticoagulation, do you start warfarins directly?
No, sir, warfarin is time, so we generally don't start it directly. We overlap with Clexane or
Why?
heparin. because it has both procoagulant and anticoagulant action.
Delayed onset of action.
It's not delayed onset. It is right procoagulant. What does this procoagulant story?
So since it inactivates both clotting factors and protein C and protein S.
So just remember protein C, protein S, these two words, which causes what?
Which will, I mean, they are
Something to do with the skin. It will cause severe skin necrosis.
Yes.
If starting because of the problem to do with the protein C, protein S. That is why you overlap with heparin. Okay. I mean, is there any such funda for overlapping heparin and all your
for
newer-
direct, we don't need any overlap, sir. We can directly switch.
Then why is the option B and C are given?
Both are given, sir. That's why I got confused.
Because you got confused, but there is a very clear answer. You have to continue for 6 months. Okay.
Yeah. Yes.
Okay. Even we had another question previously also. So 6
6,
months.
C is the answer here.
C is the answer here. Okay.
Sir,
And
but
D will be the answer if the patient is unstable.
sir, low molecular weight heparin, generally we give it for a week or 10, then switch over to oral now, sir.
It doesn't matter. You can give for 6 months also low molecular weight. Who cares?
Okay. But we can directly start also, no, sir, direct oral.
Yes.
Then
So
why
that
not?
is there is very clear answer. Continue for 6 months, which is not there in B.
Okay.
Okay. So
We don't know whether B alpha had 6
question
months or
and
not.
this is an acceptable trick.
It was given anticoagulants, continue anticoagulants for 6 months.
Yeah, true. Correct.
Yeah.
Okay. So that is why they wanted you to remember 3 points. One, are you able to know wherein you will do thrombolysis? And are you able to remember this switch is really needed or not? And third thing, whether are you going to do for a short term or a long term? Another question told some 3 months also, right?
That is for superior small saphenous vein thrombosis.
Superficial vein thrombosis.
Right.
SVT.
Mechanism of anthracycline cardiotoxicity.
Damage by reactive oxygen radicals.
Sir, few sources mention even top 2B as mechanism, sir.
That right. But drop 2 as a mechanism is more sorry.
It's more specific to top 2.
I'll tell you both things. One is most common is oxygen free radical, that is reactive oxygen radical damage. Leave around. Where is this topo 2 or drop 2 in cardiocytes? What is the importance of that?
So they are usually involved in the DNA damage repair post anthracyclines. They are inhibited. It is contributory to cardiotoxicity.
So that is a very small mechanism. One. Second thing, anything else to do with the efficacy? Anything near this gene?
Yes, sir. HER2 amplification in the breast
that is
cancer.
why they thought anthracyclines are helping in HER2 also. What is HERA paradox?
No idea.
Sorry. What is HERA trial? Sorry. No, I mean, I'm not asking trial for you to remember the name. See, the first trastuzumab trial, which told us that trastuzumab can be given for a period of 1 year than 2 years is HERA trial. Okay.
Yes, sir.
In that trial, the benefit was around 8 to 10%. Just keep a rough number. That is from 60 to 70%. Means 60% of patients need not were in the control arm. Means they never got trastuzumab. So HER2 positive patients without trastuzumab are able to survive in 60%. This is called HERA trial paradox. Understood?
Yes, sir.
Why that discussion came in? Yes. So this HER2 is actually near this. That is why anthracyclines are believed to have an effect on HER2 positive tumors. Okay.
So answer is Ras, sir.
So didn't understand.
Anthracyclines are also helpful more in HER2 positive breast cancers because this TROP2 or what is this TOPO2 or TROP2 or whatever it is,
Top to
that gene is near your HER2 gene. So that was one of the mechanisms proposed for anthracyclines to be effective against this HER2 positive tumors. Clear?
Okay.
Sir, here answer is free radical damage.
Sorry? Answer is free radical damage is the most common.
Okay, sir.
Right. Sealing effect. That is answer there. Okay.
Adding further dose will be less likely to produce effect.
Yes. What is this?
So fentanyl.
Fentanyl.
Right. Why not fentanyl?
Further respiratory depression, it will cause further respiratory
Understood.
depression.
But why? How? That is very clear. No, but how? Which others are partial or complete? All
There's
these
a mixed agonist antagonist. Fentanyl is a
fentanyl, which is a very strong agonist.
strong agonist.
So what is included in corona score? Oh my God, corona score again and again.
Pre-chemohemoglobin.
Pre-chemo HB.
The worst case is when they started asking the leukocyte count, 11,000, 10,000 was another question. Horrible to the core. So just remember, high risk is stomach and pancreas. So that is why. So which patients of cancer should have a anticoagulation?
Core 3 and above, sir.
Yeah. 3 and above, 2 and above. More than or equal to 2. Okay.
Okay.
What does this imply for us?
So all pancreatic stomach cancer patients need
Exactly. According to corona, allowed corona, you are supposed to give anticoagulation for all stomach and pancreas. Clear?
If we haven't read corona, we can rest the case, sir. In exam.
Which is the most important catheter nursing care?
Sterile hand technique.
Yeah. Horrible questions. Not flowing or slowed. How do you manage?
Stop infusion and look for warm collection signs.
Extravasation. So obviously you will stop. Leave the needle in place. Do not remove the needle. Try to aspirate as much as you can with a bigger syringe. Do not put a manual pressure over the extravasated site. Then remove the cannula and mark with the pen. Notify physician. You will notify yourself. Then you administer drug-specific antidote. You will have to elevate the limb and administer analgesia. Okay, every point is important here. Irritants, vesicants, irritants, and non-vesicants. Tough to remember, doesn't matter if you remember or not. Just remember there are 3 columns. Vesicants, irritants, non-vesicants. Vesicants, again, there are 2 classifications. DNA binding compounds, non-DNA binding compounds. Okay. Very often the questions are from Vinca alkaloids, which are again vesicants, and anthracyclines, which are vesicants. These 2 are the most commonly asked questions. So stop, disconnect, identify the agent, and then all that which I told you. Then if it is vesicant or if it is non-vesicant, local dry cold compress. Vesicant or irritant, you will have to either do disperse and dilute or localize and neutralize. Disperse, dilute only for 3, localize, neutralize for again 3. All A's for localize and neutralize. Right? I remembered localize anthracyclines, localize antibiotics and alkylating agents. Localize means How to localize? You are supposed to give cold compress. That is how you localize. 20 minutes, 4 times a day for 1 to 2 days. And then neutralize, you are going to give antibodies. You have only 2 antibodies, DMSO and dextrazoxane. Where do you use dextrazoxane?
Anthracycline.
Anthracycline.
Called DMSO. Okay. Where else do you use DMSO?
Mitomycin.
In BMT cryo.
Bone marrow,
Where?
I mean, to store transplanted, bone marrow aspirate
It's not store. What is that called?
to cryopreserve.
Cryopreserve. Okay. Only predominantly DMSO in oncology is used in 2 areas. One is this and the other one is that. Okay. Disperse dilute, zinc alkalides, taxanes, platinum salts. Every word is important. This whole chart is so much important. Remember, try and remember everything. Even if you are going into your practice, try and remember. Warm compresses, again 20 minutes, 4 times a day for 2 days. The most common mistake is people put for 5 minutes, take the, it is either warm or chill, they take it off. And for dilution, you use hyaluronidase. Okay.
Okay, sir.
Anthracyclines, dextrazoxane. Right? What is this? What is the most common complication?
Infection and
Heparin flush block due to fibrin clot.
So there are 2 complications. One is infection, other one is clotting. Which is more common among this?
Clotting, sir.
Clot.
So DVTs are commoner than infection. I don't know what was the question here.
Catheter related.
Right. What is this?
15 mg.
15 mg.
15
1/6
mg.
of the dose of morphine.
30 mg.
6. 1/6.
1/10.
1/6.
So what is IR? What is SR first?
So IR is given
What is
4
IR?
hourly. SR is given
Immediate
12
release.
hourly.
Sustained release.
Immediate release. SR is
Sustained release.
sustained release. Okay. So immediate release is used when and sustained release is used when?
Immediate release is used for breakthrough
sustained
pain.
release for baseline pain management.
So for breakthrough pains, you are supposed to give your IRs.
Yes, sir.
Long-term pain management, SRs. Clear? Just like your insulin, bolus and your basal insulins. What is the answer?
15 mg every 4th hour.
15 mg was based on what?
1/6 of the dose.
1/6 the dose.
Good. Next.
Regulated
Allow
dose.
regular.
Sir, can't it be 1/10?
1/10 is 9 mg. Sorry.
30 mg for 24 hours. 30 mg it will come around.
The SR is given BD or TID?
It is supposed to be given BD.
Yes, sir.
Here they are given TID. So
Question it was TDS. Sir.
that is what another. So it is supposed to be given only BD. Yeah. So I actually calculated for 180 mg. So the initial question itself is wrong. Well and good, 1/6 is acceptable.
So then if you calculate for 180 mg, it will come 30 mg.
Yeah, that is a problem. Initially, I thought when I was preparing this, I thought it is, SR alone. I didn't see that twice. So if it is twice daily, it is 30.
So will they give marks for these questions? Like
No
these
idea.
questions are wrong.
I don't know who will give the marks. Is it a human or an AI again?
Okay.
And how will AI decide questions of AI based questions? it will tell, yeah,
So if somebody points out the mistake, then it will accept or not accept. But if nobody's pointing out,
and A will tell, okay, medical oncologists are good, A is bad. How is it possible?
considering it has 5 to 6 questions on AI itself.
Right. As confused you are, same is me. Right? So advantage of infusion pump.
To
It's
allow
not regulated.
regulated
It's
drug.
like
I didn't get you.
B.
Sir, I don't think we can regulate the dose.
no, it was not exactly regulate. It was like correct, precise dosing or something like that.
It allows for patient ambulation, but I'm not sure about faster delivery.
Patient to choose infusion rate, yes or no?
No, sir.
No.
No,
No.
sir.
Faster delivery, patient ambulation, yes or no?
No, sir.
No,
No.
sir.
No, sir.
Slow and steady delivery, yes or no?
No, sir.
No, sir.
Maybe.
B is the answer. But it was not exactly regulated. It was more like precise dosing, something like that.
Correct dosing, something.
Yeah.
So this is back to your pharmacology. There is something called as drug delivery system. Infusion pump is one of the drug delivery systems, which will make sure a regulated dose is given. So if you are able to, if you want to give 2 ml per hour of so much micrograms per ml per minute, that is your regulated dose.
Sir, question was implanted infusion pump, sir. For implanted infusion pump, I think we cannot set the rate, right?
No, it was not implanted.
Something
No,
new.
sir, it was not
It
implanted.
was not implanted.
So if the question was patient controlled analgesia, then C option would have been right, no?
Which one? Patient control
If it was about patient controlled analgesia,
Yeah.
then the C answer could be correct, no, for that.
That you should tell me what was the question.
No, for this question, sir, it was B only.
Okay. So all except it is B.
Yes, sir.
Yes, sir.
What is this?
So they are psychosocial issue.
As the answer or as the question?
Anxiety of
Any question?
Oh, what is the answer?
Anxiety of recurrence.
Well and good. That is very, very common. Every symptom will remind them only of cancer.
Democles syndrome.
Yeah, what is that?
Democles syndrome.
Okay. What does the doctors get?
Secondary Democles syndrome.
Medical oncologists do get some syndromes. Go back, read for Harrison.
Okay.
Because of all these patients' syndromes, you do have some syndromes. Not now, once you become consultants. All are true about cisplatin except it's a highly hematogenic. What dose of cisplatin is highly hematogenic? Weekly dose?
100 milligram per 3 weekly dose. 100 milligram per minute.
Both.
Irrespective of the dose. Okay. What dose of carboplatin is highly hematogenic?
4 and above, sir.
They used it more than 4.
More than 4.
Adramycin?
Equal to 4.
More than
More
60.
than 600.
600, no one will give.
60.
More than 60.
60.
Any other drug with dosage as a criteria for calling it as high hematogenic?
Cyclophosphamide.
Carmazine.
Paraben.
Melphalan more than 140, sir.
Just remember these numbers enough.
Okay, sir.
What is this?
Ibrutinib.
Ibrutinib.
Aclabrutinib. Aclabrutinib, does it have this side effect?
No,
Yes, sir, but
No,
mild.
less.
What is called as on-target effect and off-target effect? How are the generations of drugs developed? More and more specific towards the receptor and less off-target effects is how the generations come in. Okay.
Okay, sir.
So ibrutinib is first generation, second generation BTK is acalabrutinib. Because even more specific to the
Covalent, non-covalent, what are these?
again, trying to make covalent bonding is improvement in your generation. Making it more irreversible is improvement in generation. Okay. What is this? How do you actually approach a patient with polycythemia? Patient comes very common again in your OPD. When you declare yourself as a hemato-oncologist and hematologist, you'll see these patients also. What do you do for them?
We'll hydrate them usually, sir, and
What,
then
he comes in OPD, you will call him and put on saline.
smoking history we take.
Smoking, yes, smoker. This is from Harrison. Increased hemoglobin. Measure your RBC mass. I'll tell you all this stuff very shortly. So EPO levels are low is polycythemia vera. Okay. High
Yes, sir.
EPO levels are something
Secondary.
the desaturation. Very common in smokers. Why smokers? Smokers have more carboxyhemoglobin. That is called smokers polycythemia. If there is not a smoker, but still arterial saturations are low, it is something to do with the systemic AV shunting or something to do with the heart and the lung. Okay. If saturations are low, normal, non-smoker, no cardiac effects because the saturation is normal, then there is a problem of hemoglobinopathies, which will have a problem with the oxygen affinity. This is very gross and easy way to approach a polycythemia. Clear? So in history, you will ask for smoking. Invest and then you will check if there are any signs of desaturation or not. So this is second point. Third, you will do an erythropoietin level, from which point it is easy for you to understand. But what is the approach which is asked here?
They have not asked about given about erythropoietin. So how can
they have asked your approach based on the plasma volume. So based on the plasma volume, it can be relative or absolute. Okay. Low plasma volume is relative.
Okay.
Okay. Absolute increase in red cell mass, the plasma volume will also increase. Means it is not dehydration related polycythemia. Clear?
Okay.
So here it is normal plasma volume. So it is not low. So it is increased red cell mass only. Here also increased red cell mass. So relative is out. Okay. So apparent polycythemia is out.
Okay.
It's either Vera or secondary with or without hypoxia. With or without hypoxia, they would have actually given you the value of saturation. So answer is?
They didn't mention anything about
Polycythemia.
saturation or high EPO, sir.
So answer is what?
Polycythemia.
Vera.
That's all. That is how you have to think.
The
These are
JAK2 status.
Sorry.
For
Nothing.
JAK2 status is not important.
JAK2 status is not important. Not all polycythemia areas will have JAK2. Okay.
Okay.
Here.
So it's not a diagnosis of exclusion, polycythemia vera. Like we should rule out the secondary causes, only then we can diagnose.
Yeah. For all polycythemia, secondary causes are more common, no?
Yes, sir.
Smoker is more common than any polycythemia vera. Annual MRI. This is like Xerox of any table. So what is the answer here?
Previous history of breast
Previous
cancer.
history of breast cancer.
So previous personal history of breast cancer, insufficient evidence to recommend for or against MRI. Oh my God. Easy to remember is yes, radiation, something is there. BRCA, yes. First degree relative, yes. That too with the BRCA carrier. What is the answer?
SCLC.
SCLC.
What is this?
Tyrosine kinase inhibitor.
Okay. Lenvatinib, sorafenib, thisnib, dapatinib are there. When do you give this?
So when do you use TKIs in differentiated and undifferentiated thyroid cancer?
And that is what differentiated thyroid cancer. What is given in the bracket?
When iodine is refractory, we use some
What is
radioactive.
in the bracket?
Papillary, follicular, oncocytes.
No, radioiodine refractory.
Okay. So how do we come to know it is RI refractory?
And there is no uptake which was present previously, and now it is absent. Then it favors radioactive refractoriness.
Clear?
Okay, sir. And so for dedifferentiated thyroid cancer or undifferentiated?
Undifferentiated thyroid cancers, do you use
Radiation will not.
For
Do you use
differentiation
TKIs?
therapy, sometimes they say no, if we use ATRA or TKIs, it can become differentiated.
All are high-fi stuff. Leave it.
Okay, sir.
So among this, lenvatinib for all your differentiated thyroid cancers. As a category 1, sorafenib also yes. Cabazantinib if progression after lenvatinib or sorafenib. Okay. For medullary cancers, RET inhibitor.
RET inhibition, yeah.
Right? Sorry, just a moment. Yes, back. Sorry. Right. Sulfur-cardenum, cabozantinib, vandetanib. For disease progression or symptomatic disease of medullary carcinoma, you have options of chemotherapy as so. Which other thyroid cancers chemotherapy is given? Are you people here?
Yes, sir.
Which other thyroid cancers are chemotherapy given?
Undifferentiated in refractory
Anaplastic.
setting.
Okay.
Anaplastic. Okay.
What is this?
Dexaroxane.
Dexaroxane.
Okay. Answer?
Ivabradine.
Ivabradine.
Okay.
So ivabradine is also mentioned.
Let's go. Dexaroxane, yes.
Yes, sir.
Yes. Liposomal, yes.
Yes, sir.
Yes.
Yes, sir.
That is why liposomal doxos have a high dose for developing cardiotoxicity. Okay. But still it is given in very small doses. Why? You give 30 per square, not even 60 per square. Why?
Better delivery into tissues.
And also severe mucositis. So we are expecting better delivery. So lower doses are better. Longer infusions of doxorubicin, what do you use?
Biacop, sir.
Wake up, not infusion, man. All your epoch regimens, infusional chemotherapy regimens. Okay. Epoch regimen is nothing but CHOP E given as an infusion. Okay. I wanted you to go through some of these peculiar numbers and these are guidelines. So, cancer therapy related cardiac dysfunction means LV ejection fraction more than 10% to less than 50%. Okay. And or are global longitudinal strain of more than 15% relative to baseline. Less than 1% of cases manifest acutely. Within first year, 98% of the cases. Late onset is more than 1 year. Dose dependent. threshold between, this is for high risk cardiac failures. Mechanism we just saw. High risk patient means whoever has other risk factors along with the, anthracyclines will worsen very soon. For them, imaging and biomarker evaluation every 3 to 6 months. And annually for more than or equal to 5 years post-treatment. Dexamethasone recommended for patients who have received a cumulative dose of more than 300 mg per square.
So we'll start it once they cross 300 mg.
No, this is given patients. It is for preventing and by is cardiac guidelines recommended for patients who have received a cumulative dose of 300 mg per meter square. Infusion duration of 6 hours or longer reduces the risk of clinical heart failure. Regulated liposomal doxorubicin, even at doses more than 500, no problem. Some hyperkalemia. What is this? Is sorry.
Answer.
Evaporating.
Your answer is evaporating. So,
Yes.
and dexamethasone, yes. Liposomal, yes. 96 hour infusion, yes. All these are preventing, not is evaporating. Here it is hypercalcemia.
In 96-hour infusion, the Cmax will be less. Like it won't be the cardiotoxic dose.
Yeah, about more than 6 hours, it will not be cardiotoxic. 4
Okay.
days of daily 24-hour infusion. Pulmonary domain better than level domain. Why?
More potent.
More potent.
How more? 10 times more. Okay.
Okay, sir.
100 times more than your thalidomide. Hematotoxicity, neurotoxicity less or same?
Same as lenalidomide, sir, but compared to thalidomide, very less.
Thromboembolic events, yes, no.
Same, sir.
Yes, thromboembolic events are also yes.
Same.
All these are more potent. Pembrolizumab induced myocarditis, steroid resistant. What is the answer?
Abatacept.
Infliximab.
Abatacept, anakinra, infliximab, adalimumab.
Abatacept.
Right. Workup and evaluation. As I told you, any immune-related adverse events, do all your possibilities for that symptom. If it is cardiac, do all your cardiac workup. See, alemtuzumab, that is CD52 blockade, or abatacept, which is a co-stimulatory molecule blockade, are considered as additional immunosuppression in life-threatening cases who are not responding to steroids. Clear?
Even infliximab is mentioned there.
Yeah. And this is either, this is for, see, high dose corticosteroids and addition of either mycophenolate or antithymocycline and infliximab. Abatacept and alemtuzumab mainly for immunosuppression in life-threatening cases alone. Will you ever stop steroids in these settings?
No, sir.
So basically, even without an immediate response to high dose steroids, you will still
Continue steroids.
continue steroids, early institution of steroids, and addition of this agent. As you have told, addition of all these agents are given. By answer, if you ask me also, abatacept is right, infliximab is right. What to choose? I don't have an answer for this.
So infliximab, it is used in caution with heart failure, no? So
This is purely on an IRAE, and this is your ASCO guidelines for IRAE, which has all this. Right, let the AI tell us what is the answer. Neutropenia mechanism, what is that?
So what is the mechanism of neutropenia and febrile neutropenia? I think something like that
is
was.
apoptosis. Okay. Afatinib not useful in
Exon 20 insertion.
exon 20 insertion.
Yes.
Late 58R, exon 19, yes.
Yes, sir.
What is G716X? These are rare mutations.
Rare
Do you
mutation.
remember this question? Afatinib was one, which is apart from exon 19 and L8. Geftinib, erlotinib, only exon 19 and L858R. That's all. Dacomatinib, what you should remember, that gave an overall survival advantage. That is the only point. Afatinib, what is the extra point? Apart from
Rare.
19 and L858R, rare mutations. Rare EGFR mutations. Except exon 20 insertion. What are the treatments for exon 20 insertion?
Amivantanab. Earlier mobocertinib was also there.
With chemotherapy.
Yeah.
Amivantamab with chemotherapy. Mobocertinib, yes or no?
It's withdrawn
Now
now.
removed, sir.
It's withdrawn now.
Why?
In phase 3 trial, it didn't show benefit.
No, more of toxicity. What is this? Chalo, peripheral line only for me also.
Pick line.
Symptoms?
Yes.
So not
Yes,
pick line.
Asterisk.
Is this pick line? Do we use pick line so frequently in your hospitals? I-5 hospital then.
So we use chemo ports only for all our
11,000.
patients in corporate hospitals.
Ah,
If they're like,
The
Peripheral line.
peripheral lines in government hospitals we
Ah.
commonly use.
so
AV
what is the
cannula.
most common used
And
line?
AIMS
How
also.
many patients? It's peripheral line only.
Use this
What is the answer here?
A, sir.
11,000.
11,000.
Fantastic. So much content into that. What is here?
God only.
C.
There are 15 questions.
Orientation.
for
A.
this. Huh?
C.
Ah,
No, sir.
Orientation, sir.
Why is it-
Orientation.
one second.
C.
We'll go one by
E.
one. 15 self-administered questions. Yes, I just saw yes, sir. Desire, satisfaction, components are there. Yes, sir.
Yes.
Radical prostatectomy doesn't take questions which cannot be answered by patients of erectile dysfunction.
What does that mean, sir?
I cannot understand the English only.
It doesn't include questions related
To radical prostatectomy.
So that is false. No, like we'll do it after radical prostatectomy only, like to assess erectile dysfunction.
This questionnaire itself is for patients of cancer, mainly post prostatectomy. Okay.
And so it can be for people of all sexual
erectile-
orientation. Like, why is that wrong? Like, it should be A.
So C option was like a patient with all orientation, like patient orientation was not sexual orientation.
Yeah, but it means sexual orientation only, no?
Replica of
Update-
question of
Update mentions that IIEF currently can be useful even for men with all types of sexual orientation.
Right, okay.
So A is the answer, no?
C is the answer.
No idea. I don't know what is A only here.
Sir,
Sir,
it was a replica of one of the
narrow
question
question
banks,
bank.
sir.
Sorry, okay. Again, what is this?
IIEF.
Okay.
I.
What is the answer here again? This is only a horrible question.
Malignancy.
Malignancy.
Exudative massive effusion with low pH.
So, but
So
most
they-
commonly it will be malignancy if the patient is already
They
a cancer.
told patient has lung cancer and gave this scenario, sir.
Right. Malignancy, exudative massive effusion accepted. Will it have a low pH?
Yes, sir. Like,
Yes, sir.
Why is the pH low in exudate?
Consumption of oxygen.
Consumption of oxygen by whom?
Cells or bacteria if it is exudative.
Good. You are only with the answer bacteria. Then why did malignancy come up as an answer?
So the patient himself has lung cancer.
So what? So why is this
So
low?
the tumor cell metabolism will lower the pH. The metabolism of the tumor cells will lower the pH.
Usually, bacterial effusions will be mild to moderate, sir. It was a massive effusion they have mentioned.
That is another point towards it. Yes. Taken for granted malignancy. Leptomeningeal mets common in
Melanoma.
hello.
Sir, it was most commonly
You're asking
associated with
overall
breast.
most common or higher propensity? Overall
was
most common will be breast
frequent.
and propensity will be melanoma.
Breast is the answer.
Yes, sir.
Okay. Breast, lung, melanoma among these three.
Breast.
It was like
Most.
frequent. They asked in question.
Okay. So breast is the answer. Accepted?
Yes, sir.
SPCO with respiratory compromise.
Stenting.
Endovascular stenting.
Stenting.
Genuinely, I don't know the answer. Why will you wait for a stenting in a patient with respiratory compromise?
Ideally, there should be elective intubation, emergency intubation as one of the options.
Yeah.
But that option was not there.
At least chemo and radiation fairly you have ruled out, yes?
Yes, sir.
Among these two, endovascular stenting and balloon angioplasty, it is stenting. That is the most correct option. Accepted. Not true about olaparib?
90% excreted by
Excreted by kidney.
Okay.
B.
B for ball or D for Delhi?
Delhi, sir.
Very good. Cytopenias are common lab abnormalities. Hypomagnesemia also common. So 90% is excreted by kidney. So how is it excreted?
Urine and feces.
Yes.
90% number is wrong.
Yeah. Half. 50, 40.
Yes, sir.
Doxorubicin, irreversible cardiotoxicity. Understood. What is the most common phase?
M phase, sir.
M phase. S.
Got it? Got the answer? I too thought M phase. After reading, I came to know it is S phase. This is a properly referenced article. Okay.
Sir, but most chemosensitive is G2M phase.
So this reference doesn't say anything about chemosensitivity.
Now, what is the question?
Question
They
was
asked about action, not regarding
chemosensitive phase.
sensitivity.
That is why I highlighted this mainly act. You also gave me as mainly act.
No, sir. The question was most chemosensitive phase of cell cycle.
Then that question should have been that way. I have been searching this mainly act a lot. So what is the
Where
most
is this reference from? Like with they act in cell S phase?
So what is the answer if you have the question as most chemosensitive phase?
M phase.
Okay, accepted. What is the answer here?
Benzodiazepines.
Morphine, why not? How can you give morphine?
Depression, respiratory.
Very good. So that actually will help you in allaying your dyspnea. Okay.
Sir, what was the answer for that last question?
This one? Morphine.
Yes, sir.
Yeah. Morphine is good in a patient with dyspnea because just not because it brings down your respiratory rate and patient will be off dyspnea. It also increases the oxygen delivery. It has so many effects apart from reducing respiratory rate alone. Okay. Answer here is benzodiazepines, not to give. What is this? Lynch syndrome. How common is Lynch syndrome? What is the most common cancer of Lynch syndrome?
Colon cancer.
Colorectal.
This 5 to 10% is in endometrial cancer. So don't remember this number. This slide is from endometrial cancer. So colorectal is more common, followed by
Endometrium.
Endometrium.
just remember these two. Other all are variable. Okay. So third most common line we will never know. What is true?
Most commonly causes
D.
non-keratinizing.
Yeah. D for Delhi. Does it affect outcome?
Yes, sir.
Yes. Does it have the
Sir,
same response to chemo?
it is a keratinizing cancer.
Oh. HPV is
Non-keratinizing. It is
as
non-keratinizing.
tobacco and
HPV is
alcohol is
non-keratin.
keratinizing. Okay, it will be like this. Tobacco will be left. Right side is non-tobacco. That is HPV. Okay.
Yes, sir.
That is one of the reasons that HPV related cancer we are trying to de-escalate. De-escalation, good or bad? I mean, correct or wrong?
It's good, sir. Long-term
Good, sir.
toxicities
That's
can
why
be
I asked the
avoided.
next question, correct or wrong?
Trials did not demonstrate effectiveness.
Basically, we are not supposed to de-escalate.
So why not?
Why not de-escalate? All your trials were negative. When they try to de-escalate, there is a drop in survival.
Even for HPV positive.
Even for HPV positive, you cannot de-escalate. If patient
Okay.
has cisplatin eligibility and cetuximab eligibility, you are supposed to use cisplatin. Okay.
Okay, sir.
So what is the answer here?
Apoptosis.
Apoptosis. Perfect. So it is targeting the dividing cells. Chemotherapy will target the bone marrow precursors. Induce apoptosis in mature neutrophils and their precursors also. That is how it is going to shorten the lifespan of neutrophils. Toxicity of capsaicin and syndrome. So much. What is the mutation seen for diarrhea?
DPD.
DPD.
For previous question, the mechanism for neutrophil dysfunction is NADPH oxidase dysfunction, but mechanism for neutropenia is phagocytosis, no sir?
Neutrophil dysfunction in febrile neutropenia, most common mechanism is apoptosis. All others are also possible. Phagocytic defect is possible. Okay, but which among this is most common mechanism causing neutrophil dysfunction in febrile neutropenia is apoptosis. That is why you want proliferation, you are giving GCSF, no?
Yes, sir.
So much on oxaliplatin also. What does it give?
Cold induced dysesthesia. So we can ask the patient to avoid cold exposure.
What is it? What this symptom is predictive of what?
Neurotoxicity, hypersensitivity.
Later neurotoxicity, severe neuropathies can happen for such patients. What is correct?
Correct.
Sorry?
Survival advantage.
False positivity, what I saw is around 10 to 12%. Okay, here also they are given 4 to 11%. Survival advantage is there. We'll have to know the other two options for us to kind of know whether it is right or what was wrong. Exact answer to this question is unknown. Okay.
Yes, sir.
Some Kaplan-Meier image-based question. What was that?
They are asked to
Plot of
identify the
Kaplan-Meier was given.
Kaplan-Meier.
Identify Kaplan-Meier.
Yes.
Okay. You know, now there is development of AI deciding on how the curves should be.
So like it will predict what will happen.
It is going to do the statistical analysis for making the KM curves, not your SPSS softwares. AI will decide which curve will have a better predictions and how will it predict your PCRs and stuff. How will the survival be? Possible predicted survival.
So wouldn't that create a bias?
Should. This is just into the first line news have started. Probably by 10th line of the news, we'll get into the real problems of AI. Right, what is this? Fever spike soon after starting chemo.
CRIPSI.
CRBSI, very common in your practice. Any patient chills, rigors, fever, it is catheter-related bloodstream infection. Not useful.
Why does it occur soon
Electrin.
after chemotherapy? It should occur irrespective of chemotherapy, right?
Even if you give saline, it will occur.
If there is detachment and breakdown of the biofilm, no? So it occurs even if it is flushed, the IV line is flushed.
Yeah. And you might not have a culture positivity always. Answer alectinib. Most common histology.
Small cell.
What is this?
Oxalic.
Oxaliplatin.
So thermal hyperalgesia is a marker of early oxaliplatin neurotoxicity and may predict severe neuropathy. Okay. Most chemotherapy-induced neuropathies improve after drug is withdrawn, but oxaliplatin might have a long-term neuropathy. A significant number of patients. No treatment curative available. What is this called? Last line. Last but one. Worsening neuropathy, even after stopping the drug. What is that called?
Coasting.
Casting, coasting, however you tell it as.
And so it accumulates in the dorsal root ganglia. That is the reason for that.
Good. What is this here?
B.
Good. It is it dose dependent or not?
So it is dose dependent, but 400 units.
Okay. So age, cumulative exposure, kidney dysfunction, cigarette smoking, colony stimulating factors, thoracic surgery, high fractions of inspired oxygen. That is why you don't give oxygen soon after desaturation in bleomycin lung toxicity. What do you give?
Steroids.
Steroids, where?
Antifibrotic agent.
Correct.
Tetanic.
Defibratoid.
Defibrillators. Suppose sarcoma treated with doxorubicin. What is the toxicity? What do they expect here?
No, sir, it was the same question where
Hypersensitivity. Due to lipodox hypersensitivity.
Okay. What is this?
So it is
Basal cell carcinoma.
basal cell carcinoma not seen in anal cancer.
Anything can be seen except signet ring or adenocarcinoma. Adenocarcinoma will be called as
Rectal cancer.
Rectal
lower
cancer.
rectal cancer. Okay, good.
Sarcomast.
Sarcomostim. What is filgrastim?
GCS.
Granulocyte colony stimulating factor. Only granulocyte colony stimulating factor, not monocyte.
Romiplastim.
Thrombocytes.
Okay, oprelvectin. Platelet ka count, total count. So recombinant interleukin 11.
Sir, adeno can be seen in anal canal cancer, no, sir?
You will call it as lower rectum. You will not call it as anal cancer. Okay.
If it arises from anal words, sir?
You will call it as lower rectum still.
Sir, we will treat it as a lower rectum, sir.
Yes,
Or we
sir.
will call it as
anal canal.
We'll treat it as rectal cancer, no?
So basal cell cancer usually occurs in the sun-exposed areas. Can it occur in anus?
Then
And
not
melanoma will occur in anal canal, but not basal cell carcinoma.
which one?
Melanoma might occur in anal canal, but not
Yes.
basal cell carcinoma.
Right. This is a doubtful question. I'll get back to you on this also for sure.
Okay, sir.
I think that is already battery down. I'll finish off with one or two and then we'll catch up. What is a drug? What is an intervention? For which cycle?
Epinephrine.
Next would be means next cycle or wanting.
They
Next
wanted
step.
to know for next cycle, sir.
Or
Next step.
Next step.
Step, sir.
Next step.
So next step.
next step means what?
Next
to
step.
do?
Epinephrine shot.
No,
Epinephrine.
the question clearly had mild infusion reaction, sir.
No. It did not mention mild. It just mentioned paclitaxel infusion having hypersensitivity reaction at third cycle or second cycle. What would be the next step?
Next step would you cannot reduce the dose.
I think it is
You can give
epinephrine.
epinephrine shot.
No, give steroids.
And pre-meds with next cycle. Obviously, you would have given for this cycle also. No. When do you
That's
give
what
this?
that's what the confusion.
So we can change the formulation of the drug. No, why we will give cremaphore? We'll use some other formulation, which is cremaphore free.
Yeah, right. But how was the reaction? Severe or mild?
So it
No,
can
it was
worsen.
not
We don't
mild.
know. Like, why will we take a chance?
So change drug is also a right option if your argument is right.
And like it was
Most
drug formulation.
appropriate
I think it
option
was
will be
formulation.
epinephrine only, no, sir?
Immediately, sir, to stop allergic reaction, will give epinephrine shot only.
Yes, sir.
That is a problem. So this question can be framed in our own words.
So
According to-
paclitaxel hypersensitivity is not mediated by IgE. It is due to histamine release. So we'll give antihistaminics. If it was anaphylactic shock, then we'll give like epinephrine. And they already said it's mild.
Right. For you to decide how was the question. If it was mild, probably epinephrine is not the answer. If they have not put the mild in the question, epinephrine seems to be the best answer. Reducing the dose is obviously not the answer. Change of drug is almost again not the answer because the patient has developed allergic reaction. Change of drug, if severe allergic reaction, change of drug is acceptable. You can change to napacli or docetaxel. Giving
It was
steroids,
change the formulation. Like I think it was formulation change.
right? These are the points. I think as of now, today we'll end the session. Few more, I'll finish it off very soon. Okay.
Okay, sir.
Good night. Thank you.
Thank
Yes,
you.
sir.
Thank you, sir.
Thank you, sir.
Bye-bye.
वालेकुम सलाम। अरे वो प्रोफेसर सरकमा का क्वेश्चन था तो समझे नहीं। सब लोग एक साथ बोल रहे थे, कुछ तो समझ में नहीं आया। लाइपोडॉक्स देते हैं, हाँ, तो उसका क्या हाइपरसेंसिटिव होता है? ट्रोपोसिस सार्कोमा में डॉक्सिसिट्रिबिन रहता है, तो उसका सबसे मोस्ट कॉमन एडवर्स रिएक्शन क्या रहता है लाइपोडॉक्स का? अच्छा, तो उसका आंसर क्या है? अच्छा, मेरे को तो क्वेश्चन भी याद नहीं है, आंसर दिया। नहीं, ऐसा नहीं है, मतलब लाइपोडॉक्स के इंडिकेशंस अलग है और डॉक्सिरुबिन के इंडिकेशंस अलग है, मगर हाँ ये है कि लाइपोडॉक्स में कार्डियोटॉक्सिसिटी इतनी नहीं होती कि अपने रेगुलर डॉक्सिरुबिन। अच्छा, तो उसका ठीक है। तो क्वेश्चन ही ऐसे थे, मेरे को तो एग्जाम के टाइम पे लग रहा था ये भी हो सकता है या ये भी हो सकता है, अब दोनों में से कौन सा चूज कर। और लाइपोडॉक्स का मोस्ट कॉमन साइटोटॉक्सिसिटी इन एडीआर इन क्या है अपना ये कापोसिस सार्कोमा, ये तो बोल रहा हैंडफुट सिंड्रोम रहता है। आंसर्स आएंगे तो मालूम नहीं, मतलब रिजल्ट आएंगे ना तो अच्छा शॉक रहता है। साई कृष्ण रेड्डी को कृष्णा बाना के नाम है। वो अखिलेश गोयल, हाँ अखिलेश गोयल को ने वो बहुत दिख रहा, उन्हें भी पूछते रहता शर्मिष्ठा के जैसा। हाँ, मैं वही लिखी एक्चुअली, मगर मेरे को डाउट आ रहा था कि यार वो L1 पे तो स्पाइनल कॉर्ड एंड हो जाती और उन्होंने सेल स्कोर ये वो कुछ बोले नहीं, मगर फिर भी मैंने शायद वही मार्क करी जहाँ तक मेरे को याद आ। एक्चुअली मतलब उन्होंने क्लियर नहीं बोले ना स्पाइन स्टेबल है अनस्टेबल है क्या करना है मतलब, और वो एज भी ज्यादा है उसकी, मतलब आई डोंट नो। नहीं तो L1 पे तो स्पाइनल कॉर्ड कम खत्म ही हो जाती ना, वो बस उसके वो रह जाते हैं वो कॉर्ड टाइप ना। सर बोले आरटी से वर्टिब्रल बॉडी कोलैप्स हो जाती है, मतलब वो बढ़ जाएगा। मेरे को बस मैं मालूम वो सेंस स्कोर में ने वर्टिब्रल कोलैप्स के, हाँ वो ज्यादा पॉइंट्स है, हाँ। अच्छा, नहीं नहीं, ऑलरेडी अगर फ्रैक्चर है, ऑलरेडी फ्रैक्चर है और उसको और आरटी दिए मतलब समझो, तो उन्होंने बोलते वर्टिब्रल बॉडी ऑलरेडी मतलब कॉम्प्रोमाइज है और उसको और आरटी दे दो और ज्यादा कोलैप्स हो जाता है, ऐसा बोल रहे हो। कंप्रेशन मतलब वही वर्टिब्रल बॉडी कोलैप्स हो जा रही। बिल्स की स्कोर दिए थे ना। नहीं देखो, मैंने क्या रियल लाइफ में देखे, हमारे पास अब कोई भी स्पाइनल कॉर्ड कंप्रेशन का पेशेंट है तो ना हम ऑर्थोपेडिक सर्जन को बोलते हैं कि देखो, उन्होंने बोले कि नहीं सब स्पाइन स्टेबल है कि नहीं, अगर स्पाइन स्टेबल है तो उन्होंने अपना रेडिएशन के लिए भेजते, जो स्पाइन स्टेबल नहीं है तो उन्होंने सर्जरी के लिए जाते। अब वो सिन स्कोर पे मतलब डिपेंड करता, मतलब काइंड ऑफ लाइक, अब वो अपने को उन्होंने ऐसा कट ऑफ बताया कि कितना सिन स्कोर है तो अपन उसको सर्जरी के लिए देंगे। हाँ वो तो एल्गोरिथम तो है, मतलब वो स्टेप्स है, स्टेप्स तो है, मतलब वो मैकेनिकल है, न्यूरोलॉजिक है, सिस्टमिक डिजीज और ऑन्कोलॉजिक। हाँ